Welcome to the Limitless Ladies Network, a women's holistic wellness podcast where our mission is to help women build holistic self-care. The following disclaimer applies to all episodes and content shared on this show. The views and opinions expressed on this podcast are those of the host and guests and do not necessarily reflect the views of Limitless Ladies Network or its affiliates. The information and advice provided on this podcast are for general educational purposes only and should not be considered as professional medical, nutritional, or therapeutic advice. The content shared on this podcast is not intended to diagnose, treat, cure, or prevent any disease or health condition. Listeners are advised to consult with a qualified healthcare professional before making any changes to their diet, lifestyle, or health routine. By listening to this podcast, you acknowledge that you are aware of the limitations and potential risks associated with the information and advice shared on this show. You release and hold harmless Limitless Ladies Network, its hosts, guests, and affiliates from any liability for any damages, losses, or injuries that may result from the use of the information and advice provided on this podcast. Hello, and welcome to the Limitless Ladies Network, where we're here to talk about some new holistic wellness topics today of prolapse. One of those very sensitive topics that not all of us like to talk about, but I feel that they're super important. So joining me today, I have Samantha. How do you pronounce your last name?
Ebner.
Ebner, thank you. She's a doctor of physical therapy with over 10 years in the field and the owner of Thrive Women's Wellness, which I absolutely love that it's thriving. A physical therapy, Pilates, and integrative wellness practice for women. She has a passion for working with pelvic health in women of all ages and enjoys working with those in the perinatal time frame up through menopause. Pelvic floor dysfunction is a common impairment across the lifespan, and prolapse, or POP, is a prevalent in about 50% of women, which is a staggering number, I have to say. And it's a condition I believe that we can all deal with if we have the right tools, right?
Mm-hmm.
So thank you so much for joining me.
Absolutely. Yeah. Thank you for having me. We were kind of chatting before. I said I'm always happy to talk about pelvic health for whoever will listen to it. So if I have an
Yeah, I
audience, this
mean,
is great.
it's one of those taboo things, but we really all do need to kind of learn and educate a little bit more on all those things so that we can be more prepared later on in life when can become a problem, right?
Yeah, yeah. And that's one of the big things I hear is when I first evaluate somebody is that they say, "Gosh, I kind of wish I knew about this before. Like I just had no idea this could happen, you know?" And I'm like, "Yeah, but how would you have known? Who would have told you?" You know, we don't talk about these things as often. And it's becoming bigger in the field. I feel like we're or in the world of women's health in particular, we are starting to kind of discuss it more, talk about it a little bit more, where it's not quite as taboo. Because people do need to know about these things. It's our bodies, you know, and we have the right to know, and we have the right to access to care and being able to kind of find ways to manage some of these symptoms that we're dealing with. So,
Absolutely. I
yeah.
mean, I kind of seeked you out in this for my own personal reasons, actually. I had recently gone and seen someone for prolapse because I was having some discomfort in other areas. And of course, there's the urination and frequency of that. And then you have the intimacy issue where it can be really painful. And so my OBGYN didn't really give me too much information, but I kind of just sought out various different people trying to get some information. And so I did actually go to, I guess it would be a surgeon actually, because when I had asked specifically for a woman, they were like, well, we only have a male in the office if you had to have surgery. And I was
Mhm.
like, okay. So I made that appointment. Totally uncomfortable,
Oh,
right, to have that discussion with a guy.
yeah, yeah, yeah.
Um, but it was necessary. So, I mean, it was good to be able to just go in and have that discussion and kind of get things as a baseline, I guess, to figure out where I am in the process.
Hmm.
Because he did do a pelvic exam, which
Hmm.
I was in the office, and he said, I could do a pelvic exam or not. And I'm like, well, I'm here. I mean, like,
How else are you gonna know,
how
right?
else are you, how
Yeah,
else am I truly going to know what's happening unless you do
absolutely.
something?
Yeah.
So, hence how I actually came about your information was through that office visit. But definitely, if you can share with us, some of the common signs and symptoms of what prolapse is, because I have to say, I was very shocked when the first question that he asked me was, well, is your uterus falling out? And I was like, no.
How would I know? Yeah,
I
yeah.
was like, I don't think so.
Yeah, yeah. That's usually a good sign. If you don't think so, it hopefully isn't.
Right.
But yeah, so I think that the easiest way to address this is to first even just kind of give a quick little visual of the pelvic floor, which I have a little model, because most people again don't really know what that is and what it even looks like.
Right.
When people come in and they say we're doing pelvic floor therapy, they think, okay, I might be doing some pelvic exercises on the floor. I had a woman tell me that once, and I said, no, it's going to be a little different than that. So
Yep.
you just don't even really know what it is. So just a quick orient. If you're looking at the pelvis, you've got your pelvic bones on either side. This is the front, your pubic bone.
Yep.
In the back, we've got the lumbar spine, your sacrum here. On the bottom, you'll see this is a group of the external layers of the pelvic floor muscles. Those are your more superficial layers. You have the opening around the anus, around the urethra, and the vaginal opening here. So those are your sphincters. So that's going to help to kind of close everything up when we want things to stay in, and it's going to relax when we want things to come out. If you look on the inside, I'm actually going to take all the organs out, but you have a better kind of bird's eye view. So those are the muscles. These are the main kind of deeper muscles, that third layer that helps to actually support the pelvic organs. Um,
Mm,
and so your pelvic organs being your bladder, which sits right in the front here. And then you have your uterus, if you have one. Some people have had
right.
hysterectomies. You can still have a prolapse, even if you have a hysterectomy. That sits behind the bladder. And then your rectum, which sits behind the uterus. So they all kind of fit in there relatively snug. Now, a prolapse is essentially a descent of any one of those organs down through the vaginal canal, through that opening. So typically we would see on the front portion, that's more, we would call that a cystocele, which is more the bladder kind of dropping down. It's a pretty common one. I mean, any of them are common, to be honest. In the back, if you have a posterior canal kind of prolapse, you're looking more at the rectum or even the intestines. We call it an enterocele. So either
Wow.
one of those can actually kind of drop down through that vaginal opening. And then in the middle, or it could be the cervix uterus. So that's kind of the middle vaginal vault that's kind of coming down and exiting through the vaginal canal. Now, that being said, there are varying degrees of, and I know that you kind of touched briefly on that in terms of like what the stages are. The easiest way to define it actually is starting at stage two. So it's stage one to stage four. And stage two is going to be the organs have kind of descended to that hymen remnants there. So kind of right at the opening, or just above into that vaginal opening. So they've descended down to that point within a centimeter above or below that opening. Um,
Okay.
so that's a stage two. A stage one would be above that, anything above that. Stage three would be below that, but not actually exiting the vaginal opening. And stage four is going to be the organs have actually protruded outside of the vaginal opening. At that point, people are definitely noticing, they're definitely having symptoms. You would know, you say, oh, something's definitely falling out of me. So one of the questions I ask, when I first see people, do you feel like something is falling out of you? So those are the degrees in which we're kind of looking at prolapse. And those are assessed, a physical therapist, a pelvic floor physical therapist can assess that. A urogynecologist, your regular gynecologist can assess that. There are different measurements you can take to get pretty nitty gritty in terms of the specifics of it. Um, but the stages vary, and treatments kind of vary within the stages as well. So just kind of getting that initial diagnosis though of like, oh my gosh, like my organs are coming down and falling out. It seems kind of scary right off the bat. And again, maybe not getting as much information about it right away, like, okay, yeah, something's falling out. It's a little
That
like
sounds pretty serious,
it
right? I mean, I was shocked when he was asking me if, my uterus was falling out. I'm like, I really don't think
I
so.
have no idea. Yeah. And
Yeah.
depending on which organ, or again, it can be more than one, is coming down through that vaginal opening, you can have some of these symptoms. And, the pelvic floor is responsible for bowel, bladder, and sexual functions. Any of those can be disrupted when you have a prolapse like this. So, and again, depends on the degree. Um, but obviously, more symptom bother is more more likely to make you seek out care or question, like you said, okay, especially if you have like pelvic heaviness, that's one of the things that people report of,
Mhm.
heaviness, or maybe it is urinary urgency frequency or stress urinary incontinence, like you're actually losing urine. And oftentimes it's issues with constipation, even, you're having a hard time fully evacuating the bowels or fully ridding the bladder of urine, or sexual discomfort, so there, again, depends, definitely a big degree of symptom bother or variety of symptom bother that can occur.
Right. And those
Um,
are things that, you know, it could be affecting a lot of things just based off of what you've eaten, right? Maybe you're constipated because you had gluten, like me, I'm gluten sensitive, right?
yeah,
So maybe you're just
yeah.
thinking that's what it is and you're like it's a prolonged thing, or could be anything, right? It's like normal everyday life that you're running into these things and you don't really think that your organs are kind of slowly slipping away, right?
Yeah, and it's one of those things too that, again, you can have these variety of symptoms, and some people will actually have, a grade 2 prolapse and have no symptoms at all,
Mhm.
or, grade 1, but they do feel it. Or they're more aware of their body or more in tune to things. And they're like, no, I definitely have something there. So it all depends. But we deal with and treat the prolapse really a lot based on your symptom bother. If it's not really bothering you or you're not really having some of these symptoms, a lot of times people will feel like they've got like a tampon that's just hanging there, or there's a golf ball. Like, it just feels like all this heaviness, and it's really uncomfortable, and it can get worse throughout the day because gravity,
Right, right,
or if you spend a long time standing, I mean, throughout the day, you're on your feet, you work in a field where you're on your feet all day. I mean, absolutely. There are different things that can certainly cause symptoms to be worse. And again, maybe be better the next day or certainly be better in the morning. So
right.
definitely,
That
definitely
makes
depends.
sense.
Yeah,
So,
yeah.
what are some of the, like, who would typically be affected by prolapse? It sounded like it can affect anybody because I was thinking mostly women, but
Mhm.
men as well.
Yeah, it can, but yeah, we're primarily seeing it in women, obviously having that vaginal vault. I mean, in men, you can have other kind of issues with the rectum and everything, but certainly with women, you're dealing with any of those organs that are prolapsing down through the vaginal opening. And oftentimes we think of it being women, which is, the biggest risk factor would be pregnancy and a vaginal birth. Um,
Right.
and, there are a lot of other things that kind of go into that, and that could probably be a whole nother podcast. But it's not just women that have had a vaginal birth. You can see it in people that have chronic constipation. So some people have never had children and they can still have a prolapse. Chronic constipation, um, obesity, any increased pressure down on the pelvic floor, people
Mhm.
with chronic coughs, that are constantly coughing, that's bearing down that a lot of pressure down on the pelvic floor over time. Heavy weightlifters, that Valsalva maneuver, we're really kind of putting that lot of pressure down. There's a genetic component to it as well. If your mom had a prolapse, it's more likely that you might have a prolapse. It could be a connective tissue disorder. Um, when it comes to vaginal birth, though, too, and again, not everybody who's had a vaginal birth has a prolapse either, but increasing number of children, increasing the size of, larger children are going to put you at increased risk for prolapse as well.
Right.
Um,
Being a
so
runner.
yeah, yeah, again, that heavy impact, absolutely,
Yeah.
absolutely. So definitely a lot of different things can put you at risk for it. But again, not everybody that's at risk is going to get a prolapse. But I think like we were kind of talking about, it's it could be at least 50% of women, and that's just in the literature that's kind of showing that 50% of women have a prolapse.
Right. That's like the reported ones of women that actually have gone
Exactly.
and were
Are
seeking
part
out
of
some
studies.
assistance,
Yeah,
right?
yeah, yeah. No, it's very common, and oftentimes, sometimes it happens. We have a vaginal exam, and it was more of an incidental finding. They didn't even know they weren't having symptoms because not many of those people are having symptoms. Not symptom bother by the prolapse, but
Right.
a lot of people are walking around with these symptoms because there are a lot of people. A lot of people have had children, and again, that does put them at risk. But one of the biggest things, actually, I also want to talk about is as we age, because as we're aging, that estrogen is going down. Estrogen's great. We love that. Beefs up the tissue. It helps to support the pelvic floor and give more support to the tissue to hold everything up and in. And as you work into that kind of perimenopause, menopause stage of life, you don't have as much estrogen. And so we start to
Right.
see more of those issues. And whether or not that coincides with, maybe some people are gaining weight over time, not always. Maybe there are other things, if you have a progressive cough over time as you get older. I mean, it could be a variety of a combination of things. But yeah, that kind of de-estrogenized tissue certainly puts you at risk for prolapse as well. And in terms of how that treatment is going to go forward, too, in terms of what they're going to do for management. So
Right. That makes sense. I
yeah,
mean, because if it's not lubricated enough there, it's going to cause some issues with it just kind of getting dried, right? And then
absolutely.
things just as the heaviness happens, it makes sense that it
Yeah,
would just kind of start to
yeah, not so
pretty
comfortable.
faster. Yeah.
Not comfortable. And that's when people tend to kind of seek care. Is okay, we've got these issues now. Maybe it wasn't bothersome before. Maybe you don't know that you're having an actual prolapse or something's kind of coming out of you, but you know something's not right. And then you go and you get checked and it's like, okay, well, this is what you have. And now what are the options? Now what do you do?
Great. So let's talk about some of those options.
Yeah, yeah. So a few different things. One, which is very common, is watch and wait, right? Like we're just not really going to do anything. We're going to see what happens. I don't really want that to be an issue. I don't want that to be a thing anymore. I'd rather, if it's going to be watch and wait, it should be go to physical therapy or
Right.
occupational therapy. A lot of occupational therapists also do pelvic health, but getting some sort of treatment, I think, is good. So watch and wait should kind of be out. Not really one of those options, but that is
Which is basically what the doctor told me.
yes.
What? Well, let's just see
Right.
you in a
Let's
year. I'm
just see how
like,
it goes. Yeah.
okay.
Well, let's not, let's
Yeah.
do
How about
something
you give me
first.
that list of people that I could
Yeah,
possibly work with that would give me
yeah,
information about this instead of
exactly.
waiting a whole nother
Exactly.
year
Yeah, right,
when my
right.
numbers increase? Yeah.
Yeah, right. I mean, why not do something about it now?
Right.
So yeah, watch and wait / physical therapy, which we can talk about a little bit more. Use of pessaries, which I'm not personally certified in fitting, but some physical therapists, pelvic floor physical therapists are certified to do it within their realm. And your gynecologist, your regular gynecologist can also fit you with a pessary, which is essentially a device that you just insert into the vaginal opening, and it does help to support those organs. And many people do very, very well with them. That tends to be a pretty good long-term solution if you feel comfortable with it, you get the right one. And I usually will tell people if that's something that is an option that they're going with. Don't give up if one doesn't work because there are a lot of different kinds out there. Um,
Really?
yeah, and some of them work a lot better with different kinds of prolapse too, and certain stages as well.
Okay.
Different stages and where the prolapse is, especially a bladder prolapse, that's a little bit more common. And
Is that like a permanent kind of thing, or is it somewhat like putting in a contraceptive device where you take it in, take it out as you will, sort of?
yes, yes, yes. So it is more something that can be removed. They can stay in for a while, some up 3 to 6 months, some stay in longer than that. Some take
Wow.
them out, you can take them out to be cleaned. But again, lots of different options. They've got some now on Amazon, variations that you can actually do. And you can actually use them yourself. It works best if you're working with a therapist or somebody
Right.
and go over, how to actually use it and how to put it in and make sure it fits and is doing its job. But I've worked with women that, really do well with pessaries and they've been able to run and been able to, do Pilates or horseback ride, whatever. It doesn't matter what you want to do. I mean, our goal, especially in physical therapy, is to get you to do the things that you enjoy doing without your symptoms.
Right.
So whatever that looks like, and it's walking, maybe it's just playing with your kids. Like it doesn't matter. I mean, whatever you're having symptoms with, you want to be able to manage and deal with that. So pessaries can be a really good option. And then the most obviously invasive thing would be to do surgery. And there are a few different kinds of surgeries, again, depending on where the prolapse is, the stage of the prolapse, whether or not that's appropriate. Somebody with a stage 4 prolapse is not really appropriate for physical therapy. There's not much I'm physically going to be able to do at that point.
Right. Right. It's kind of
Um,
beyond the threshold of being able to self correct, right?
yeah,
So is
yeah.
that usually, like you said, it's 1 to 4. So
Mhm.
is that threshold somewhere around 2?
Depends.
Okay.
A lot of people can also manage their symptoms, stage 3 with a pessary. And so I say pessary, but I always like that conjunction with physical therapy, at least initially, because one of the big caveats of even using a pessary, even using or having surgery is if whatever's happening. So let's say apart from de-estrogenized tissue or other kind of risk factors and other things, there is still something going on in the system that has caused this prolapse to happen. And there
Right.
are some risk factors that we can change. Managing intra-abdominal pressure, managing constipation, managing bowel and bladder habits, some of those things, those are really important. So if we don't change what's happening and then do an intervention, it could potentially get worse. I have
Right.
seen
You got to
repeat.
get to the root cause.
You got to get to the root cause, because if you have this surgery and you're still loading the system and loading the tissue the same way after the surgery, depending on the kind of surgery, some are, pretty successful and do great. But I have seen repeat surgery,
Mm,
or failed surgeries where maybe it wouldn't have failed if we also did it in conjunction with physical therapy and say, hey, let's figure out how to manage your pressure better because, a lot of it has to do with breath work, breathing. That's what I do a ton of with my patients is managing what that pressure looks like and with specific activities. So
right.
you kind of need to have that piece as well. I think that's really, really important to do that kind of in conjunction with whatever, intervention you kind of choose to go with. So
Definitely.
yeah, yeah.
So tell us a little bit more about the actual physical therapy piece. Like what does that look like when someone comes in for a session?
Yeah, no, great question. So it depends on what their symptoms are, obviously, but I will always do a pretty subjective past medical history. I want to really know what's going on. And it might be from, I might be working with somebody in their 60s or 70s, but have you always had constipation? Have you always had this? I mean, I need to know did you have any children? Like, we really need to get a pretty thorough subjective history. And then the objective portion, I'm looking at the whole body. I mean, we look at posture, we look at how you're holding tension in your body. What's your rib cage doing? What does your back look like? Where does it appear that you're holding tension, and where does it appear like maybe there's some weakness? So I do a quick kind of external orthopedic view of things. Kind of zone out from the pelvic floor, look at what's happening at the feet. Again, probably another whole podcast on how the feet are relate to the pelvic floor. But then we do an internal evaluation. So we'll actually do an assessment. And this part's kind of interesting because particularly when you're assessing for prolapse. Now, I can almost guarantee you that you had an internal assessment that was performed on your back on the table.
Yes.
Most people are not experiencing their prolapse symptoms when they're on their back on the table, right?
That makes total sense to me.
Right. So I do a standing
This is why I wanted a woman to be
yeah,
able to do the whole thing
yeah,
for me.
yes. So I do standing internal assessments because what's interesting, I mean, I do both. I do it on the back, and then I want to know what's happening because if you have, I say, okay, I want you to bear down like you're having a bowel movement, and I get this, movement of, one part of the vaginal wall. All right, that's all well and good. But what happens when you get up? And then I'll kind of go and I'll actually just insert my finger, kind of create this little shelf there and see what kind of pressure comes down with different movements. So we're doing this, and I'll have people lunge. I'll have them pick up a kettlebell. I'll have them do a little squat. You would think this would be weird, and it kind of is at first to sort out,
Yep.
movement, but it's amazing what kind of happens because other parts of the system actually start to kick on and kind of help support the pelvic floor.
Mm,
Sometimes it doesn't always happen. But I won't know that unless I assess it. So
right.
we need to kind of see what's happening. I mean, is it worse in standing? Is it worse on your back? Is it worse when you squat down or you bear down or you jump? You do a quick little jump up because it might not be or it might. And I won't know that unless we do a true assessment. So,
I mean, that's great information to know, right? Like I would
yeah,
love to know that as I do my self-defense kickboxing classes and they make me
absolutely.
do, jumping jacks, which I hate doing.
Yeah.
Like,
And it's
you're
like,
you're ruining my pelvic floor.
but maybe it's not. You never know. I mean, there's a certain amount of intra-abdominal pressure our pelvic floor needs because it does kind of reflexively kind of protect and will kind of work against that pressure.
Yep.
Um, but everybody's body's going to react differently. And
Yeah.
everyone uses different systems in their body. Like not everybody, we always say, I say this to my patients all the time, the patients don't read the textbook. This is the way it's supposed to happen, but it doesn't always work like that.
Right.
So you kind of have to see how everybody is responding individually to the task that they're doing, because the demand could be different. They might be really strong in their glutes, or they might be really weak in their core, or their adductors, their inner thighs might be really tight, and those are working harder than they need to.
Mm.
So all that does, so internal assessment really gives me a good picture of what that looks like. And then based on the findings and the patient's goals, what does the patient want to be able to do? I mean, that's the biggest thing. It doesn't matter
Right.
what I want them to be able to do or what I think they should be able to do. It's if the patient wants to run or they want to hike or they want to be able to pick up their grandkids or, whatever they want to do, we try and simulate that here.
Yeah.
And now I also have a Pilates-based background, which is kind of one of the reasons I got into this whole thing was I was working at a Pilates-based clinic, um, and I loved it. And it was physical therapy and Pilates, and I kind of noticed like all these women would come in. It tends to attract, that kind of a clinic. It tends to attract more women, 30s to 70s, and they do their classes on the reformer, and they'd all like go to the bathroom first. And I'm like, well, that's kind of odd. And I wasn't really practicing pelvic floor physical therapy at the time. So it was kind of, seeing all these things that they were always complaining of, not, I don't want to say complaining, but like reporting like, okay, I don't want to pee when I'm doing this, or I don't want to have an issue
Right.
or feel kind of pressure. So I'm just going to go to the bathroom first. So I'm like, I think I need to learn more about this. And so that's when I kind of deep dove down into more of the pelvic health field, and then also got certified in Pilates. Um, the Pilates is really cool because you can do a lot of strengthening on the reformers, which I've got a couple reformers back here.
Yeah.
It puts you in a gravity eliminated position. So it takes the prolapse symptoms typically out of the equation for the most part. Like when you're doing stuff on your back, there are a lot
Right.
of things you can do on the reformer, but I like starting people there because we can work on breathing. We can work on hip and knee, strength and stability and range of motion, coordination of breath with the core activation and different things. And then when they're feeling pretty good there, then we can get them up, change orientation of gravity, and then start doing some exercises there that kind of carry out more into the real world.
Yeah. That's
So
amazing. So
yeah,
how long does a session, like, how long does the assessment usually take? Is it an hour or a little
yeah,
longer?
it's an hour. I'm a one-man show, one-woman show. It's just me, so I am grateful that I have the ability to do it however I want. So I allot an hour for my initial evals, but they usually do run over quite a bit.
Yep.
And then the follow-up treatment sessions are about an hour. And again, it's all one-on-one. It's just with me. And I do a combination of manual therapy, usually hands-on stuff, and then the strengthening piece. And the manual therapy depends on what the findings are. Some people, and this is a little bit of a paradox, and people don't always realize this, but sometimes there's actually a lot of tension in the pelvic floor and tightness in those muscles. And tight muscles do not mean strong muscles. In fact, tightness
Hmm.
usually means weakness, believe it or not, or it's strong in one range of motion. It's not, that we want flexibility and strength. We need both, as we do in all of our muscles.
Right.
But so if there's tension in the pelvic floor, we need to kind of address that, work on that. Or if there's tension in the abdomen, abdominal grippers, and we're kind of trying to get a lot of our core control from that. I do a lot of work on the mid back, especially when I'm working with my new moms who have now just spent all this time being pregnant and now are carrying baby and feeding baby and changing baby forward, or even just people that are working on a computer. We have so much this forward
Yes.
posture, right? And so the upper back gets tight. When the upper back gets tight, the ribs don't move that well. So here I am telling you, okay, let's take a deep breath, and the upper back and the ribs aren't moving. So I do work there. So pelvic
Wow.
floor therapy is not just working right on the pelvic floor. It's really working on the system around it and how it affects the pelvic floor. So it really, everybody's treatment session is going to be pretty individual because it's what are our findings? Because no two people are alike. So kind of wild.
Yeah, that's
Yeah.
great. I mean, I love that you really do take a absolutely holistic approach to
Mhm.
treating one, you know, kind of small muscles, I guess, right? That we don't really think about, but yet it's amazing how it really impacts our entire body.
It does, absolutely. And the pelvic floor is also very closely related to our nervous system too. So I always address people's nervous system. We call it kind of upregulated. People that are higher tone and maybe they're holding more tension in their body, or people that are lower tone, which I don't see too often. But
Not
maybe we can.
nowadays, right? Everybody's more like
Oh yeah,
on
absolutely.
edge.
Absolutely. And the pelvic floor responds to that, that reflexive guarding. Absolutely. So we work on nervous system regulation. We work on sleep. We work on nutrition. I mean, there are all these components that, when we're dealing with a pretty unique part of the body that is really affected by all of those things. And if we don't look at all of those things, we're kind of missing the boat on, making pretty good gains long term. So yeah, kind of cool.
Yeah, that's awesome.
Yeah. Yeah.
Well, this was great. Lots of information.
Yeah,
I'm
yeah,
glad to know that you're out there as well as other
absolutely.
practitioners that can help us ladies before it gets to be too late and we
Yeah,
end up having to have surgery.
absolutely.
So, Samantha, tell us, where can our listeners find you?
Yeah. So best way to reach me definitely is through email because I'm not so good about answering my phone as I'm, usually with patients. But email, and you might get an email at 10 o'clock at night. But my email is thrivewomenswellness@gmail.com. And my website is thrivewomenswellness.com. I also do have an Instagram at Thrive Women's Wellness. And those are the main places that you can really kind of connect with me. But I have my practices in Glastonbury, and yeah, I love seeing patients very passionate about what I do, and I really enjoy it. I connect with everybody that comes in here. I have a great patient population, and they're appreciative. People just want to know, they want to learn, and I love to educate. That's one of my favorite things. Like I said, I'm like, oh, if I had an audience to talk about pelvic health, like
I
sign me up.
know. And we all need to start listening
Yeah,
because it has
yeah,
such a major impact on our life, especially in our later years. So
absolutely.
why should we be suffering when we know
Yeah,
that we can actually be thriving?
absolutely. Don't wait for sure. Yeah,
Absolutely.
yeah.
So this was great. Of course, I encourage all of our listeners to follow us on Facebook and also on LinkedIn. Limitless Ladies Network, sign up for our email where you can get insights from this podcast and also other recipes, also any events that are going on, like our Smashing Pumpkin event that we have going on that's supporting a local farm on this Sunday. So please make sure that you follow us and connect with us.
Awesome. Great.
Thank you.
Thanks.